and welcome back to When IT Hits the Fan, brought to you by Rhyno Healthcare Solutions. I'm Christy Patillo. Today we have with us Dr. Simita Mishra. I have been so excited to get this episode recorded just from our pre-interview. We had such a wonderful conversation. Thank you for being here, Dr. Mishra.
Absolutely my pleasure. Thank you for having me, Christy.
And so we're going to start off with the question I always start off with. Who are you and what do you do? Give us some perspective on your expertise.
So as you already introduced myself, I'm Simita Mishra. I am a doctor because I have a PhD in medical informatics and population health. I have primarily been working in the healthcare space with a majority of my experience around population health management, moving the needle from volume to value-based care, and working with different integrated delivery networks to ensure that they are doing the right thing to really achieve their goals around population health and care coordination.
Let's start off with your academic journey. Again, you have your PhD in medical informatics, and you are involved in such an important part of the healthcare industry that's often overlooked because it's what stops people from getting into the hospital and keeps them there for as short a period of time as possible and make sure that they don't return in all best health. Can you tell me a little bit more about your journey? What was it like earning your PhD? Any other degrees you have?
So my journey started in healthcare because my mom always wanted me to be a doctor, but I am a single child, so I didn't want to go away to college so soon. So I stayed in the general line, but I promised her that I will be associated with healthcare. So when it was time for me to do my master's, I decided to do it in public health. So I got my master's back from home in India and also in an affiliation with Johns Hopkins University. So I have a master's degree in healthcare administration, followed by my PhD in medical informatics. I did my PhD comparing and contrasting between healthcare as it evolves in a third world country versus first world countries like US and few parts of Europe. So it was about the development of technology and how it enables and what are the pros and the challenges of utilizing technology to improve the outcomes of health. So that's how we evolved. And it took me a good number of years to complete it, like 4 or 5 years, but it's now long done.
So right now you're actually getting an MBA outside of healthcare. Can you tell me a little bit about that choice? What it's like on the other side, what you're learning, and what new perspectives you're getting? What's similar and what's different?
So yes, I am a perpetual learner. I just get excited about getting new certificates or medals. So part of my resolution one fine New Year's Day was, hey, I want to pursue another degree. And I wanted to pursue it outside of healthcare because I have been with an organization for more than a decade and in the healthcare space for more than 2 decades. So I wanted to see how I can diversify and see what could actually translate into the real world, which is outside of healthcare, cross industry. So I said, I can apply my subject matter expertise in healthcare management while every day we are evolving as a better professional, as a better leader. So I decided to pursue my MBA in being a better leader in 21st century. So my degree is mostly online. It's predominantly online with a little bit of hybrid component, but it is a tailored course which is created by management gurus like Jack Welch and Peter Drucker, and they're phenomenal. I have had phenomenal experience, real world application. I barely open a book to answer any of my questions because it's mostly from the real world application. I have been asked to compare and contrast myself with leaders like Satya Nadella from Microsoft or any political leader, just to understand what my way of thinking is and what is their way of thinking and how does it overlap or how diverse they are. So it kind of gives me a perspective of what I can learn from them or what I may be doing better, and even if I'm not as famous as them. But regardless, it has been a very evolving, introspective journey, and I am almost done. I'm almost a term away from completing my MBA.
Well, congratulations on another graduation, truly. And let's step back into the healthcare industry, something you said earlier. For the sake of the audience, can you tell me a little bit about what the difference is between volume-based and value-based care and what the switch is? It's very much in the zeitgeist right now, but maybe people don't know the difference between the two and why one might be preferred.
Sure. So the basic And the most layman way of describing volume is that once upon a time, physicians got reimbursed based on like RVUs, which is relative value units. As many patients as they saw, the number of patients, the more dollars they make. But eventually, as different stakeholders made their entry and the government made its entry, CMS had a vested interest, payers have a vested interest. They wanted to see how do we measure the outcomes not based, or the physician's capabilities not based on just the volume, but also the value they add to the outcomes and to the patient. So how do you measure value? Is it's not about the number of patients churned, but what was the exact outcome. Not about how many patients you really treated, but how many patients were you actually able to divert from getting sick by focusing on preventative care, by focusing on everything else that matters to them outside of just their clinical diagnosis, which we fondly call social determinants of health. And it's a buzzword. It has been a buzzword for a while in the healthcare, especially in the population health space. Social determinants of health means where does the patient live? What are the conditions that could be likely for a patient to act in a certain manner? As we talk about patient quality of care, we are talking about physician is not the only person accountable. Physicians are supposed to be able to work on top of their license. How do they utilize a team to actually make things happen and engage patients as not just a patient or a person who is sick, but as a design partner in their healthcare delivery process so that they feel empowered and they feel like they can control their outcome. And when you feel this sense of ownership, you are much more vested in making it happen. And a team vested together is always better than one person trying to make things happen. Right. So that's the whole idea behind volume to value based care. And we could go on, but I'll pause
Yes,
here.
it's obvious why, just from a humanitarian point of view, why less sick people is better for a society. But even
Exactly.
from a more pragmatic point of view, healthcare is one of the industries where actually having less customers is better for the bottom line sometimes with harm reduction. But could you possibly share a story of a practical example or something concrete of how value based care can be better for everyone all around as opposed to volume filling beds, trying to churn out as many people as possible? If you were teaching a class per se, do you have a concrete example of, say, it is easier to feed a person with diabetes healthy food for the rest of their life as
Okay.
opposed
Okay.
to
Gotcha.
amputate a foot?
Yes. So you are asking me about the whole person orientation, or basically how do you take care of a value of care as opposed to volume? So when we are looking at medication adherence, I'll give you a separate example, and I also come to the diabetes example because that's one of my favorite examples. But for medication adherence, when we are trying to track patients to ensure that they are more compliant with their medication, they are keeping up with the drugs, meaning the pharmacy, what the pharmacy has prescribed and what their physicians have prescribed. Just tracking the patient alone as to how many times they have missed a medication is only a report. We go beyond that in population health and care coordination, where we try to get to the root cause as to why the patient might be missing a medication. Is it merely patient reminder that could help us, or is it something else? If a patient has no roof or no food, they will focus on how to get some food, and so that they and their families are not hungry, how to protect themselves from rain and wind and get some shelter. The food insecurities,
Housing
the
insecurity.
housing insecurities, they are all very important when it comes to a patient's discipline. So when we are looking at medication adherence, maybe we are not just looking at what are the medicines and what are the patient's diagnosis, and if the medicines prescribed are right, how frequent, and if the patient has missed it, send them a reminder, please take your medication. But go into why they may have missed the medication and possibly try to work with other organizations, because healthcare organizations don't often have the social resources. They would have to engage with CBOs, community based organizations, to resolve some of these problems. But the idea is to resolve it holistically so that instead of just volume, value can be delivered. Similarly, with a diabetic patient, I would say that if a diabetic patient also has a comorbidity of being obese, just writing them a diet plan is not enough. They could go to a dietitian and get a diet plan, and that could help. But if you go ahead and look at what is happening in their zip code, is there a close enough grocery store where they can get fresh vegetables delivered? Or is there only fast food chains? And is that the one that they have easy access to? And obviously, fast food chains are much cheaper than fresh groceries. You get $1 a burger, you don't get much vegetables for $1. So, and then also the access. Do they have a car to get to the grocery? So instead of spending money on their diet plan and their dietitian, you divert those dollars to actually provide them the access. Maybe figure out a way to drop fresh groceries at their doorstep. That is called the holistic version of care delivery. And that is called taking care of the value of care as opposed to just the volume or how many patients that have actually been seen for diabetes.
And one can only imagine how much the quality of life goes up as well.
Yes.
And so, going into this idea of tech bringing medicine into the future, what is one of the biggest hurdles you've found in aligning IT and the clinician teams? Can you tell us about a time that you successfully bridged, or perhaps pain points along the way between these two groups?
Well, this is where informatics plays a big role, because the idea is the clinicians are physicians, like not necessarily physicians. Clinicians are people with clinical background. They know what they would require to deliver top level of care for their patients, but they also know that what they would want from informatics, but they would not know how to translate it in a language that the technical folks can understand. So, and obviously they will have a list of items that needs to be done, but it has to be prioritized given everything else that's going on, given what are the regulatory restrictions or what is doable, what is not doable. And then the IT folks cannot understand the clinical language. Somebody has to convert it into a coding language or a language that can be easily deciphered by them to actually develop a product. Again, the decisions for healthcare systems has been a build or buy. So whether we explain it to a vendor or we explain it to our in-house technical folks, regardless, somebody has to do that translation. And this is exactly where informatics sits in the cusp of IT, in the intersection of IT and clinical world. So this is where understanding the problem, developing the business requirements in a way that can be translated for IT folks to build what's needed.
And to talk on another hot button issue, provider burnout. It's a significant issue. It's something that's just turning the medical industry upside down, especially in this post-COVID world. Can you discuss the informatics solutions or strategies, or where informatics can help this problem and reduce provider fatigue and improve their day-to-day workflow, et cetera?
Sure. So physicians' work has not diminished by any means.
No.
They're still seeing the number of patients. At the end of the day, they are the people who are ultimately accountable for the patients, particularly the primary care physicians. We are trying to, as administrators of healthcare, we are trying to provide them with tools which are through informatics and technology to help them improve their life balance, so to help them improve the care delivery process. But at times, what takes over is too many systems, too many clicks. And if anything, that only adds to their burden. And we have to be very careful about not giving them the click fatigue, not overburdening them with technology, no redundancies. But that's easier said than done, because often redundancies do occur because at times you have multiple technologies that are probably trying to solve the same problem. They may have a little bit of an overlap, but they may still be different problems. But ultimately, if there is one technology which is a chatbot, another technology which is an EMR system, another technology which is a care coordination system, regardless, the same care coordinators, same physicians are working through all of these systems. They're toggling through screens and they're sending out referrals. They're sending out referrals to specialists. They're sending out referrals to these community-based organizations. It's a lot of technology usage. So we have to be careful and cautiously optimistic about the best way to handle this and not go overboard, because physicians' concerns are real, clinicians' concerns are real. I don't want to just say physicians. I mean, we have to understand and empathize about where they are coming from. Apart from that, obviously, sometimes there is a resistance to some technologies, and that doesn't necessarily is not a good thing. There is a way to do change management, which is where we apply physician advocates. When a physician or a clinician is advising other clinicians in the trenches while he is part of them, it's a little easier rather than somebody from ivory tower trying to do the same thing as an administrator. So that's a change management one-on-one that has to be robust, and that has to be successfully executed for us to really have all of these things running in parallel and in symmetry and synchronized.
And one thing that I hear echoed across many of the interviews I do, be it with data people or people on the cutting edge of AI, projects with strong potential sometimes fail to receive sustainable funding. Sometimes budgets, because especially right now, medical budgets are on a razor's edge. The budget goes to the fire of the day as opposed to building something long and sustainable that might have ROI down the road, but will take a couple years. Could you walk us through how to make a strong business case for informatics incentives, ways that they can decrease pressure and bring measurable ROI?
That's a hot button issue you have pressed. So, as things are moving from volume to value based care, technology usage is here to stay. It's not something which is nice to have. It is actually a must have. You get left behind if you're not using cutting edge technology. You're not using, we were relying on claims data, for example, to have reports that will show which patients are more susceptible for a 30-day to get readmitted within 30 days. Versus now with AI, we are trying to make predictions 45 days prior to even the first admission. So those are, and remote patient monitoring. We were looking at technology, we were looking at the patient's vital stats and creating a trend pattern for them based on whenever they're coming in for an appointment, and we are checking their vitals. But now all their measurements and readings can be continuously monitored through remote patient monitoring. Those are all technology based tools that are helping us improve outcomes. So while these amount of technologies are getting used, someone has to decode the technology between the clinicians and the technical folks so that everybody, every key stakeholder is on the same page. And this is where informatics has a role to play. It's still evolving from folks understanding how valuable informaticians are. At this point, I do not see that it has been recognized in its full capacity, but we are making slow and steady progress. One day it will become an inevitable function. We are yet to get to that day, but measurable ROI or KPIs are important. So if informatics can actually come around with each project that they are intervening or running interferences with, and defining the major KPIs for those projects along with the clinical stakeholders and the technical stakeholders, and then measuring everybody and the progress of the project roadmap based on those KPIs, rather than leaving it to some level of subjectivity as to whether the informatics really played a crucial role. Because sometimes people might think, oh, you know what, I could just go and talk directly to someone and get stuff done. I know people in this organization, and that happens more in larger organizations. To be honest, in large organizations, it's always too many cooks and a lot of hand in the pot. So the clarity of their roles, the empowerment to make certain calls, and then the clear demarcation of what their role is. I think those are evolving, and as they evolve, they will only get better.
I agree completely that I don't think the absolute value of informatics has been absorbed yet. And so, one thing that we talked about in our pre interview, and I would love if you could walk the audience through the idea first, and then we can talk more about its importance. But the quadruple and quintuple aims in healthcare, and you walked me through on your. Can you do that presentation for us?
That's actually one of my favorites. So IHI is the institute that really first introduced the triple aim. The triple aim are the three key pillars of healthcare, and that is healthcare quality, healthcare patient engagement, and the financial bottom line. Those are the three pillars because ultimately our customers are patients. they are the face, right? And then quality cannot be compromised because quality is all about outcomes, and the whole idea is to get people better. But at the same time, all healthcare organizations, everybody in business for that matter, always has scarce resources. We cannot continue to deploy tactics and initiatives without knowing what value does it add. Is there a value on the investment? Is there a return on the investment? Because ultimately, we are all answerable in some way. Like if it's a capitated arrangement with a payer, or it's a grant from a CMS, or anything else, there is a financial bottom line that needs to be tracked. So those are the three pillars. But as things progressed, we realized that with the introduction of technology, that provider burnout is becoming another thing that's real. So provider well-being became the fourth pillar. Post COVID, there was one more pillar that was added, which is health equity. Because we also realized that people can be from the same area, same zip code, but if they do not have similar kind of access and affordability, that impacted their health and their level of contagion, their level of compliance with COVID. Vaccine hesitancy also was dependent on that to some extent. So those are the five pillars now: health equity, provider burnout, patient engagement, and the empowerment that I already talked about, quality of care, and financial bottom.
Thank you for going through that with us. One thing I'll say is from our first conversation, something I loved is that you are a lifelong learner. You have this huge respect for academia and education. And so you are also an adjunct professor on top of everything else that you do somehow. Can you tell me a little bit about any emerging technologies in healthcare right now that you are excited about, something that's coming around the bend or blossoming right now?
Sure. I do teach emerging technology for about a couple of semesters a year for a university and as an adjunct for a master's program. So basically, my drive is to build future healthcare leaders who are vested in healthcare informatics. And mostly the topics that we cover are cloud-based technology, Internet of Things, and then we look at artificial intelligence. We look at digital transformation and how do you engage digital like patients through digital front door and everything. But my favorite one will always, at this point at least, I don't know if it always will be, but at this point is certainly AI and machine learning, because it kind of gives you a lot more early intervention, and any kind of early intervention helps improve diagnoses, improved outcome management. So I work with vendors, I work with internal folks to actually engage in what can be put into that algorithm that will suggest which patients fall under high, low, and medium risk, so that when we do our intervention strategy, we can divert our resources accordingly so that we can hit the nail on the head. If it's a lower risk, maybe we put a little bit less effort. Nonetheless, we are going to focus on every patient because standardization of care is a key to success of population health initiatives. But we are going to have a little bit more like aggressive intervention on the high risk ones.
Triage.
Exactly. And then also the one more thing that I have learned along the way is that impact. Sometimes a person may be high risk, but you may know that they may not be very impactable because if they are already in their end of life, or if they're in a vegetative state where it's all about just having palliative or soothing care, you don't do too many interventions and bother them too much. So that empathy factor should also be taken into play, and it is getting added more and more to the algorithms, because if patients at the end of the day are not just numbers in your algorithm, they are human beings, and there should be a touch of empathy. So that's my favorite, I would say, at this point. And I teach that. I actually have been recently, it was interesting. We actually had our students use Chat GPT, DeepSeek, and all those kind of technology to create prompts to see how they can get best solution to certain use cases. So that was one innovative way of us ending the finals for this semester. So we are introducing more in bite-sized pieces, more and more of the cutting edge, so that students are more used to and familiar with technology and these type of interventions before they join the workforce.
And we've reached the end of the show. It's time for my favorite question, which is that if you had a magic bottle, and you could put a message in it and send it back to yourself at the beginning of your career. It's hard-won wisdom that you know now that could have helped you maybe avoid a little bit of pain before. What would you tell yourself?
That's a great question. And let me keep it a little bit away from healthcare because, as I said, I kind of mix it up a little bit. I would say that I have done a master's straight out of my college. I was a bachelor's and then I went for master's. I had, ambitious and strict Indian parents. They wanted me to be extremely learned. And I enjoyed it. My mix was people who were 20 years older than me. And now I'm doing my MBA after I have 15, 20 years of experience. And I see the stark difference. I was a good straight A student at that point too, but the amount of the value I got from that course versus now that I'm doing all applications in my course studies, I'm learning so much more. My key advice to folks will be, if you are going to pursue higher education, get some experience under your belt. Before you do that, you will get the most out of it.
And I love that piece of advice. I really do. And so that actually brings us to the end of this
Wow, that was
episode.
quick and that was fun.
Really, I couldn't wait to record our episode. And so thank you again, Dr. Simita Mishra, for being with us this week. If the people in the audience would like to reach out to you in any way, shape, or form, is that something you're comfortable with? And how would they
Absolutely.
do that?
Absolutely. They
Maybe
can
through
reach
LinkedIn?
out to me via my email,
LinkedIn email, yeah?
samitamishra@gmail.com. They can connect with me on LinkedIn. I'm always happy to mentor like enthusiastic future
Dork
healthcare workers.
health geeks.
Exactly. And I really have to thank you. It's an honor to be on this podcast, and I really enjoyed having done this with you.
Yes.
Fun.
Well, thank you. I'm blushing. And this has been another episode of When IT Hits the Fan, brought to you by Rhyno Healthcare Solutions. Tune in with us next week for another professional in the field. And thank you for watching.